Hi, my name is Michael Trower, an emergency medicine consultant, and this talk is about lung ultrasound in COVID-19. But let's start first with a brief recap of the basics of lung ultrasound. So for many years, decades in fact, it was assumed you couldn't scan the lungs because they're full of air, and air is the enemy of ultrasound. However, in the 1990s, thanks to the eccentric Parisian intensivist Daniel Lichtenstein, who you can see here, he used to sneak into his department in Paris in the middle of the night because apparently lung ultrasound was forbidden there. But thanks to his pioneering work and his publication of the now famous Blue Protocol in 2008, there's now a really well-established evidence base for the use of lung ultrasound in all the most common causes of breathlessness: pneumonia, pneumothorax, pleural effusion, pulmonary edema, pulmonary embolism. I'm talking like thousands of patients, meta-analyses, really high-quality, robust data for the use of lung ultrasound. So this is normal. So we can see the ribs with shadows behind them. Then just deep to the ribs, that's the pleural line. And then these lines deep and parallel to the pleural line are called A lines. And here we can see a video clip of the same thing, normal lung. So we've got the ribs with the shadows, and then just deep to this, the pleural line. But this time we can see that it's sliding back and forth. So we can see a smooth, thin pleural line. We can still see those A lines, horizontal lines deep to the pleural line. And we can also now see lungs sliding. And those tiny little vertical lines that are coming down off the pleural line are called comet tails, or comet tail artifacts. And this is all normal. So lung ultrasound is relatively easy. In terms of the technique, first you choose your probe. So I would recommend this middle probe, the low-frequency curvilinear probe. This gives you more depth, which is especially important in your fluffier patients. But if you want to zoom in on the pleural line itself, you can always switch to the high-frequency linear probe. Then choose a preset, and if your machine has a lung preset, that's ideal, and this will automatically optimize all the machine settings so that you can see pleural sliding and all the artifacts that we'll talk about shortly. Then adjust your depth. So generally keep the pleural line in about the middle of the screen. This is usually where the focal zone is, so you'll get the best picture of pleural sliding, and also you have sufficient space behind the pleural line to appreciate any artifacts that are coming off the pleural line. So generally keep the probe perpendicular to the ribs, as shown here. That way you can see where the ribs are and you know the pleural line is just a bit deep to that. However, if you want to see a larger piece of pleura, you can rotate the probe parallel. Just be careful if you do this, make sure you are actually looking at the pleural line and you're not actually over a rib. Okay, so if your patient's well enough, ask them to sit up and hug themselves. This will bring the scapulae out the way. And hugging himself shouldn't be a problem if you're a narcissist like this gentleman. Now, a basic scan, you just slide the probe down from cephalad to caudad. And if there's florid pathology like pulmonary edema or massive pleural effusion, you'll see it quite easily just using this kind of basic scan. However, if you're searching for something a bit more subtle, then you might want to do a more comprehensive scan, which sometimes is referred to as the lawnmower technique. So this is where you slide along one intercostal space, you drop down to the next one, you slide back, drop down, slide back. And so you're really trying to survey as much of the lung surface as you can. There are a few different systems for dividing the lung into zones. The most commonly used one is to divide it into 6 zones, so 2 anteriorly, 2 laterally, and 2 posteriorly. However, I tend to just refer to the area anatomically, so anterior superior or posterior inferior, so that there's no confusion about where I'm talking about. In this video, I'm sliding down a patient's back, so from cephalad down to caudad. So you can see the ribs and the pleural line just deep to that. And as we get down to the base of the lung, this is the lung curtain. So as the patient breathes in, it comes down, and as they breathe out, it goes back up. I'll just let this clip play one more time and just demonstrate that lung curtain one more time. So lung curtain is normal, so it's just the junction of the thorax and the abdomen, so it relates to the level of the diaphragm. So here we are, the patient's breathing in, the lung curtain's coming down, and then as they breathe out, the lung curtain is drawn back up, revealing the abdominal organs beneath. So pathology in lung ultrasound is actually quite simple. There's really only 4 different things that you can see. So the Trower approach is that you just look for those 4 things, and then it's the pattern and the distribution of those things that leads you to a particular diagnosis. So the 4 things are B-lines, pleural line abnormalities, consolidation, and diffusion. So let's go through these one at a time. So B-lines are defined as bright or hyperechoic white lines that come down off the pleural line and go all the way down to the bottom of the screen without fading, so non-attenuating. And this is an example of 3 discrete B-lines on a high-frequency probe. Here we have some confluent B-lines and a low-frequency probe. And here we have some more B-lines with a phased array probe. Now, it can be normal to see 1 or 2 B-lines, especially in the bases in older people. But in a young person, even to see 1 or 2 in the upper zones is probably not normal. B-lines are not specific to anything, so they can occur in pulmonary edema, in infection, even a contusion. But sometimes the pattern and the distribution of them and the combination of them with the other lung ultrasound findings can be more specific. So the second pathological finding in lung ultrasound is pleural line abnormality. And there are 2 aspects to this. There's lung sliding, which we'll talk about a bit later, and the other one is pleural line irregularity. So the pleural line should normally be nice and thin and smooth, as we've seen before. However, it can become thickened and irregular, as you can see here. And here's another example. So instead of being nice and thin and smooth, it's now thickened and irregular, fragmented, like a rat has been nibbling at it. And the third pathological lung ultrasound finding is consolidation. So here's an example of a small or subpleural consolidation. So it's this dark or hypoechoic area that just extends down a centimeter or 2 from the pleural line. Here's a slightly larger consolidation with a bit of fluid above it. And here's a lobar consolidation. So this is the diaphragm here, this is the liver, and on the cephalad side of the diaphragm, this lung looks almost exactly like the liver on the other side. So this is also sometimes referred to as hepatization of the lung. So these small subpleural consolidations are more typical of viral pneumonia, whereas the lobar consolidations are more typical of bacterial pneumonia. And the fourth and final pathological lung ultrasound finding is effusion. So fluid looks black or anechoic on ultrasound. Here's an example of a large pleural effusion sitting just above the liver there. Here's one showing the spine sign. So this is the spine here, cephalad of the diaphragm. You don't normally see the spine, so if you do, it means there's something that's transmitting ultrasound through the chest, so it could be consolidation or fluid. And finally, here's an example of an effusion with debris within it. So if you see this, you know that it's an exudate and not a transudate. Yeah, so lung ultrasound is really quite simple. There's only 4 things that you need to look for: B-lines, pleural line abnormality, consolidation, and diffusion. There are some limitations to lung ultrasound. So in this image, the blue dot would be visible because it makes it to the chest wall, whereas the yellow dot would not be visible because there's some aerated lung between your probe and the lesion. Okay, so the other pleural line abnormality that we skipped over before is lung sliding. So here's an example of normal lung sliding. So here's the ribs with the shadows, and then the pleural line just deep to that. And you can see there's a sort of shimmering or glistening movement along this pleural line. So that's normal, and that means there's no pneumothorax at that point. Some people think it looks a bit like an army of ants marching along in a row. Whereas in this image, we can see an example of the absence of lung sliding. So this is the pleural line here, and we can see the patient is trying to move. These muscles are moving somewhat, but that pleural line is static. There's no shimmering, glistening, sliding movement. So there's an absence of lung sliding. Now, an absence of lung sliding doesn't mean 100% this is a pneumothorax, but it raises the suspicion of a pneumothorax. So you can also use M mode or motion mode to assess for pneumothorax. So in this example, this green line that's coming down from the top of the screen on the B mode image, this relates to the single narrow line that we're assessing So imagine you've just isolated a single crystal from the probe, and we're only interested in what's happening along that crystal. So here on the bottom is the M mode image. So that green line relates to this y-axis of this graph. So at the top is muscle, this bright white line is the pleural line, and then down here is lung. And then the x-axis is what's happening over time. So in the muscle, there's nothing happening, just horizontal lines. But below the pleural line, because the lung is moving, we get this speckled appearance. And so this is called the seashore sign, which is normal. In a pneumothorax, because there's air, we don't see the seashore sign, we just see horizontal lines all the way down. And so that's called the barcode sign. Now, to be honest, you don't actually need to use M mode to assess for pneumothorax. You can see everything you need to on normal B mode, brightness mode, or 2D mode. If you optimize your image, so you've got the high frequency probe on a lung preset, you've adjusted your gain, you've got the pleural line in the middle of the screen at the focal zone. Even if the lung sliding is quite subtle, you should be able to see it there on normal B mode. So I mentioned earlier that the absence of lung sliding is not 100% specific to pneumothorax. Other conditions can cause this as well. For example, pneumonia, where the surface of the lung becomes sticky, or apnea, if the patient's just not breathing at all. Hopefully you would have noticed this. However, luckily for us, there is a sign that's very specific for a pneumothorax. If you see this sign, you can confidently rule in a pneumothorax. And this is called the lung point. So this is the transition point between no sliding and sliding. So in this clip, on the left-hand side of the image, there's no sliding. The pleural line is static. But on the right-hand side, there is sliding. And if you can identify that transition point that relates to this point here on the CT, the point at which the lung has come up to the chest wall, if you can identify that, you can confidently rule in a pneumothorax. The only other condition that could possibly cause that appearance would be a large apical bulla. So the only caveat is that in a patient with COPD or known bullous disease, then you do still need to be careful and you may need to get a CT. But otherwise, the lung point rules in a pneumothorax. Now, if you've got a complete lung collapse, you obviously won't see a lung point because the lung isn't up at any point. But if you can see a lung point, you can rule in a pneumothorax. And here's the lung point again, this time with the sliding to the left-hand side of screen and the absence of sliding to the right. So the transition point just here. And you can even identify this on M mode as well. So normal seashore to the left, barcode to the right. So one other potentially useful sign to look for if you're considering pneumothorax is a thing called the lung pulse. So this is a normal phenomenon, and it occurs when the heart actually transmits vibrations to the pleural line. So imagine you've got a sick patient who's just been intubated and also has just had a left subclavian central line. And now they've suddenly crashed. Their SATs have plummeted, ventilators alarming for high pressure, and you're wondering, have I intubated the right main stem? Or maybe I've caused a tension pneumothorax from my central line. So you look at the left side of the chest and you see no lung sliding. So here in this image, there isn't a shimmering, glistening movement of that pleural line, is there? There's no lung sliding. The pleural line is also quite thickened and there's some B lines coming off it, so possibly it's a bit sticky from infection. But there's also a rhythmic movement back and forth, and this movement actually relates to the patient's heartbeat. So this is called the lung pulse. So we know in this patient they don't have a pneumothorax. You must have just intubated their right main stem. So just pull the tube back a bit and this sliding should reappear. And here's an example of one of those traps we mentioned earlier. So this is apical bully. So we'd have no sliding here and even a lung point here. Okay, the blue protocol. So I think it's important to know a bit about this because it is referred to a lot in the world of lung ultrasound. So here's our friend again, Daniel Lichtenstein. So this paper was published in Chest in 2008. It was a retrospective blinded paper of 260 patients who were all admitted to intensive care with acute respiratory failure. And he found a greater than 90.5% accuracy in some of the most common causes of breathlessness. And here is the blue protocol. So the first step is to look for lung sliding. If it's present and there are bilateral B lines, this suggests pulmonary edema. If it's present but there are A lines, then you look at the leg veins. If there's a DVT, this suggests a PE. If there's no DVT, you look at the posterolateral region. If there's consolidation, this suggests pneumonia. And if there's not, it suggests COPD or asthma. A/B is when one lung has A lines and the other has B lines. This suggests pneumonia. If there's abolished lung sliding with B lines, this is the sticky lung that you get in pneumonia. However, if there's abolished sliding with A lines, then you look for a lung point. If you can find a lung point, you can rule in a pneumothorax. If you can't, you may need to do further imaging like a CT. So that's the blue protocol. So the blue protocol is fine. It doesn't mention pleural effusion or pleural line irregularity or integrating your findings with clinical assessment or echo. So you may find the Trout approach a bit more intuitive and simpler. And so just to recap, you look for those four things: B lines, pleural line abnormality, consolidation, and effusion. Then you think about the pattern and the distribution of those things and how it fits with the typical patterns in the main differentials. You integrate with your clinical findings, plus or minus echo or DVT, and you come to your most likely diagnosis. So why use lung ultrasound in COVID? Well, there are three theoretical reasons why it's actually perfectly suited to this disease. So we know COVID affects the peripheral lung, and this is the part of the lung that lung ultrasound assesses. We know that chest X-ray and PCR both lack sensitivity. So chest X-ray probably somewhere around 60 to 70%, and PCR also only about 70%. And then there are the obvious logistical benefits of ultrasound over CT. So cost, radiation, but probably most importantly, avoiding transfers of patients around the hospital, potentially contaminating other staff and other areas. So what are the lung ultrasound findings in COVID? Well, let's break them down in terms of those four things. So B lines, these are the most common finding, and they can be confluent. The pleural line is commonly affected and is often irregular or thickened. Consolidations are less common, less than half of patients, and when they are present, they tend to be small or subpleural. And effusions are uncommon, so less than 10% of patients, and when they are present, are small and localized. But it's really the distribution of disease that is the classic thing in COVID. So you get patchy bilateral changes. So there'll be some disease, and then there'll be some normal lung interspersed, and then a bit more disease. So little patches all around the lung. Here's an example of how ground glass opacity on CT relates to B lines on lung ultrasound, pleural irregularity on CT and on ultrasound, and consolidation on CT and on ultrasound. So allow me to take you on a stroll through the evidence for lung ultrasound in COVID-19. And it's actually been really interesting to watch how this has unfolded over the year. So at the start of the year, as you'd expect, the evidence was from China. So these were a couple of small studies that found lung ultrasound correlates well with CT. Then the next big spike was in Italy. And the Italians were already known for their use of lung ultrasound. And they published some recommendations that lung ultrasound appeared to be very useful for COVID-19. Then over the summer, there were several relatively small papers from Europe and North America, all suggesting that lung ultrasound was fairly accurate. However, these papers were of fairly low quality, and I actually published a review in July that noted the relatively low quality of the evidence at that time. However, in October, there were several larger, higher quality papers published, and I think it's fair to say that there is now reasonably robust evidence for the use of lung ultrasound in COVID. So Liefeld and his colleagues from the Netherlands published this prospective blinded multi-center trial of about 200 patients, about half of whom had COVID, and found sensitivity of 92 and specificity of 71 for lung ultrasound in COVID. This was slightly more sensitive than CT, but less specific. Interestingly, they also found that of the few false negative cases, none of these patients required admission or oxygen. So lung ultrasound is very likely to identify if you have COVID, and if it misses it, it's probably because it's mild disease. This paper by Pivetta was kind of similar to the previous paper. Again, prospective, blinded, about 200 patients, about half of whom had COVID. And they found even slightly better accuracy, so 94% sensitivity and 95% specificity. Interestingly, of the 21 patients who had an initial negative PCR, but a subsequent positive PCR, so false negative initial PCR, all of these 21 were identified by their initial lung ultrasound. Sorlini was a retrospective study of nearly 400 patients, and they found a sensitivity of 92 and a specificity of 65. And this was significantly higher than chest X-ray. Okay, let's run through a case. So a 68-year-old female presents on day 8 with fever and cough. She's febrile, but saturating well, and has a borderline lymphopenia. And this is her chest X-ray. I'll give you a moment to see what you think. So it was reported as normal. And this is her lung ultrasound. So you can see some B lines coming off the pleural line there and a bit of pleural irregularity associated with it. And then in this image, there's more B lines, a thickened irregular pleural line, and there's a black rim around the lung as well. So this is pleural effusion, a small localized pleural effusion. So these signs are all quite typical of COVID. And she indeed did have COVID. Next, a 41-year-old female presents day 7 with chest pain, afebrile, saturating well, normal lymphocytes. So her pre-test probability was quite a bit lower than that first case. And her chest X-ray, I think you'll agree, is completely normal. Here's her lung ultrasound. So this is from the left upper anterior zone. So here's a big fat B line here. Now, I did say that B lines can be normal, so 1 or 2, especially in the bases in older people, but to see a big fat B line like that in the upper zone of a young, healthy patient is not normal. So we indeed felt she probably had COVID. This was at the peak of the pandemic when incidence was high, and indeed she did. So the light beam sign is where you have a big fat confluent B line that just comes in and out of view. So this image on the left, this is normal, and then suddenly, bang, big fat B line just flashes in. So the light beam sign has been described as possibly more specific to COVID than the other lung ultrasound findings. However, it can still occur in other conditions, so it's not 100% specific. But when we see a patient with shortness of breath in ED, we're not just looking for the COVID changes, we're also thinking about differentials. And the main differentials we consider are heart failure, PE, bacterial pneumonia, and asthma COPD. So let's talk about how the lung ultrasound looks in each of these conditions. So here we have lots of B lines, which are evenly distributed across these 3 intercostal spaces, and the pleural line is nice and thin and smooth. So this is the typical appearance of heart failure or pulmonary edema. If it was COVID, these B lines would be more patchy. There might be some pleural irregularity or subpleural consolidations. So you can't 100% discriminate them on ultrasound, but this is typical of heart failure. And if you saw this echo to go with it, that would build up more of a case for heart failure. So here the LV is not contracting normally. There's reduced LV systolic function. So here's a parasternal short axis view. And this is the right ventricle. This is the left ventricle. The septum is being flattened. So this is suggestive of possible pulmonary embolus. And if you also saw this big clot in the femoral vein, that would make your case for an acute PE. Here's an example of bacterial pneumonia. So there's the diaphragm, this is the liver. Again, we've got the hepatization of the lung, so it's become solid like liver tissue. And if you look closely, there are a couple of little air bubbles going up and down within that consolidated lung. They're called dynamic air bronchograms, and they're more specific to consolidation than atelectasis. Here's an example of fibrosis on CT and on ultrasound, and this is to demonstrate that in patients with underlying lung disease, like interstitial lung disease, pulmonary fibrosis, they get B lines and they get pleural line thickening, and so you can't discriminate whether there's any acute or chronic process in this group. So what are the potential roles of lung ultrasound in COVID? Well, I think the main one is just improving diagnostic accuracy. We know lung ultrasound is more accurate than chest X-ray and more sensitive than PCR. So by adding lung ultrasound into your clinical assessment and integrating it with your pre-test probability, you will improve your diagnostic accuracy for this condition. It may also have a role in guiding further imaging. So for example, if you have a patient who's hypoxic but has a normal lung ultrasound, this should prompt you to think about, could this be a PE and get a CTPA? And lung ultrasound may also have a role in terms of streaming and disposition. If you can identify patients with COVID right from triage, then you may be able to more accurately divide them into your respiratory and non-respiratory areas, and similarly for bed booking going up to the ward. This is an example of a possible lung proforma that you may like to use for documenting your findings. So we've divided the lung into 12 zones here, 6 on each side, and then this key shows you how to document your findings into each of those zones. So if it's normal, you just write A for A lines. C1 is an irregular pleural line, C2 a small subpleural consolidation, C3 a lobar consolidation, B1 is 3 or 4 B lines, B2 is more than 5 or confluent B lines, E1 is a small effusion, and E2 a large effusion. And then the second half of the form, step 2 is just about correlating your findings with the typical disease patterns. So in a viral pneumonitis, you get B lines, pleural line irregularity, sometimes subpleural consolidations, usually no effusion, but in a patchy bilateral distribution. And then also this table just has the typical appearances in all the other differentials. So it's just a reference for you to consider how the findings that you've just documented relate to the typical patterns in other diseases. And then step 3 is about integrating your findings with your pre-test probability. So before you did the lung ultrasound, how likely did you think it was that the patient had COVID? Then, based on your lung ultrasound findings, was it typical of COVID or typical of another diagnosis, like pulmonary edema, for example? And then what's your post-test probability of COVID? Okay, some take-home points. Firstly, lung ultrasound is not difficult. In terms of the technique and image acquisition, this is not like echo where it's difficult to get a view. If you stick the probe on the chest, you'll see the lung. And also in terms of image interpretation, as we said, there's really only 4 things that you can see on lung ultrasound. So it's not difficult to learn. And it also has a very strong evidence base. There's high quality evidence for the use of lung ultrasound in pulmonary edema, in pneumothorax, pleural effusion. It's really well established. And so I'd argue any clinician that's seeing patients with acute breathlessness should know how to perform lung ultrasound. And we now know that lung ultrasound is highly sensitive for COVID-19. As you saw from some of those studies, sensitivity is probably around 92–94%, so significantly higher than chest X-ray. Now, it's not as specific, and in patients with underlying heart and lung disease, it's really not very specific at all. But it is highly sensitive. If they have any significant COVID, you're very likely to see it on lung ultrasound. Well, thanks very much for listening, and if you have any questions, please feel free to shoot me an email or a tweet.